Hi everyone, my name is Shivani. I'm a final year medical student at the University of Limerick in Limerick, Ireland, as well as part of the Global Innovation Panel, as well as a faculty and mentor at NEDPRO Global Center for Nutrition and Health. So it's an absolute pleasure to talk to you about our project here that we conducted in the Red House Family Practice, which is a local rural primary care practice in Mallow near Cork in Ireland. So what we did was essentially we wanted to look at the current state of hypertension management in our practice. As we know, Ireland has one of the highest rates of high blood pressure with amongst the lowest levels of diagnosis, treatment, and management of high blood pressure. By 2020, the number of adults greater than 45 years with hypertension expected to rise to more than 63%. So this is a 28% increase in 10 years. We all know that hypertension is the number one modifiable risk factor for cardiovascular disease, and cardiovascular disease is also the number one cause for mortality globally. So this is definitely a huge burden of health on the healthcare system. We need to tackle hypertension and make sure that we're doing all the right things to further reduce high blood pressure prevalence in our community. So the European Society for Cardiology and the NICE guidelines, they've suggested the gold standard to diagnose hypertension is a 24-hour or 72-hour ambulatory blood pressure monitoring. And the American Heart Association also reduced their cutoff point to diagnose high blood pressure with from 140 by 90 to a blood pressure of 130 by 80. So that means more and more people will be diagnosed with high blood pressure. And this is very important to note because this is something that we need to target in our patients as well. So our objectives were to investigate the current prevalence of hypertension, as well as then develop a algorithm that can help our practitioners to better identify and manage patients with hypertension. I'm just going to go through our methods. Like I said, we conducted a retrospective cross-sectional audit. And in this audit, we searched for all the patients who came into our practice over the last 3 years who were greater than 25 years old, looking at only adults, and who had a BP systolic greater than 150 or a coded diagnosis of hypertension. So we use BP systolic of 150 as a cutoff point because that's usually the cutoff to start antihypertensive therapy. Coded diagnosis of hypertension refers to the codes that we put in according to the ICPC2 framework into the electronic medical records that we use in our practice. So every time a patient comes in, we code them with a diagnosis. So we wanted to capture everyone who was coded with hypertension. Then what we did is after that, we developed a management protocol based on the ESC and NICE guidelines that we then implemented in the practice. We weren't able to do an audit after the implementation of the protocol because of the COVID pandemic, but this is something that we hope to do in due course. So I'm going to quickly go through the results. We saw that we had 890 patients who came into the practice. The average age was about 65, and we had 78% who had a coded diagnosis of hypertension, while only 22% did not have a coded diagnosis of hypertension. Most of our patients were male, and they were overweight with a BMI of 29.9 and a mean weight of 86 kilograms. So we know that high BMI and smoking status lead to high blood pressure. And we also know that metabolic syndrome also leads to high blood pressure. So we can see that almost 62% of our patients had some sort of lipid disorder, so hypercholesterolemia, and 18% of our patients had diabetes. So this is definitely a significant portion of our patients who currently are at high risk of hypertension and subsequently premature cardiovascular disease. So most of our patients who had a diagnosis of hypertension were on combined therapy antihypertensive medications. However, only 20% of their patients without a coded diagnosis were on some form of therapy. So this is potentially about 80% of patients who did not have any diagnosis of hypertension, but had a clinic blood pressure of greater than 150 mmHg BP systolic that we are potentially missing. Out of the people who had a coded diagnosis, about a third did not have any ambulatory blood pressure monitoring, and out of the people who did not have a diagnosis, more than 3/4 did not have an ambulatory blood pressure monitoring. So we can see that the uptake is really low, and it's something that we need to increase to better diagnose our patients with hypertension. So in conclusion, most of our patients are overweight. They have a history of lipid disorder. So this is something that we have to tackle. There's no standardized protocol to screen for these patients for high blood pressure. And if we don't intervene in a timely fashion, then these are patients who can be at risk of stroke and premature cardiovascular disease. This is the protocol that we developed. Feel free to contact me later and we can go in detail. But we developed this protocol based on the ESC and the NICE guidelines, and we stress that there should be greater emphasis on sodium and fat intake reduction, smoking cessation, increased physical activity, moderate alcohol consumption, and increased intake of Mediterranean dietary patterns, because we have seen that the Mediterranean diet correlates with lower risk of cardiovascular disease. So we have put in exactly what clinic blood pressure we should be aiming for and what ambulatory blood pressure monitoring we should be aiming for before starting treatment. So what we did is we enabled our nurses to conduct this protocol, and we gave them the autonomy to refer all our patients for ambulatory blood pressure monitoring. So this caused an increase in ambulatory blood pressure monitoring, as well as empowered our nurses to take more charge into hypertension management. So it definitely shared the care of hypertension management between the family physicians and the nurses. So we hope to follow up on this and see how our patients are doing. We want to train more healthcare practitioners in conducting ambulatory blood pressure monitoring, as well as emphasize on lifestyle and nutrition changes within our practice. As we know, the Irish food lifestyle intake is very high in salt as well as fatty foods and fast foods. So this is something that we need to target. So this project really gave us a good indication of our gaps in care, and also highlighted where we can intervene. So thank you very much. I conducted this project with Dr. David Maloney, who's the lead of the Red House Family Practice. If you have any questions, please let me know. You can email me at s.pud@nedpro.org.uk. And thank you very much for listening. Have a great rest of the summit. Take care. Bye.